All right, I'd like to welcome everyone to our Spring Tune-In Tuesday. Let's call it Spring Tune-In Tuesday. I'm really excited to have you all with us today. We are going to be talking today about adolescent development and behaviors and some really practical, easy things that you can do to make sure that you are responding to kids in a way that's going to help you help them. So I'm really excited for you all to be here today. I wanted to let you know that our training today is sponsored by the Office of Juvenile Justice and Delinquency Prevention, and any opinions that you hear are the opinions of the speakers and not necessarily anyone from the federal government. We are grant funded today, just like many of you. All right, and then I want to go through our learning objectives before I turn it over to our panelists. We're going to do a fast hour today. And we wanted to talk really beyond those basics of adolescent development that we've talked about a lot and that you probably hear about a lot. We really wanted to get into some of the other things that affect the way a young person may present while they're in the JDTC with you, including the impacts of things like racism and trauma, and then how substance abuse and adolescent development all play a part in what you're seeing when kids come into court. So we're hoping that at the end of this training, you'll be able to describe the impact of trauma and racism on the developing brain, that you'll be able to interpret scientific findings related to substance use and adolescent development, and then that you'll also be able to identify practical tips to address adolescent behaviors in the JDTC. And I really encourage you all, when we get to that part of the presentation, to pick one or two of the things that we're going to talk about and think about how you could incorporate those into your own practice. All right, so without further ado, I'm going to turn it over to our faculty today. We have Jacqueline Van Wormer and James Puckett joining us. I'm going to ask them to do their own introductions, but I'm really excited to have you all here. Thanks.
Thank you, Jessica. Well, good afternoon or good morning to everyone, depending on your location. It's nice to see such a great turnout for this session today. And like Jessica said, it'll be a fairly quick hour, but we have a lot of information that we want to impart on you with you today. And so, like Jessica said, I'm Dr. Jacqueline Van Wormer with the National Association of Drug Court Professionals. I'm the director of our Juvenile Training and Technical Assistance Initiative at NADCP. You're probably all familiar with NADCP. We are the country's largest training and technical assistance organization for treatment courts. And so we're really pleased to be able to partner with the National Council of Juvenile and Family Court Judges to offer you this webinar. We try to offer webinars in this Tune In Tuesday series that can really be reflective of what your needs are, and also impart some practice that you can, and some information that you can transfer into practice. And joining me today, we're excited to have James Puckett joining us from the University of Wisconsin-La Crosse. And so I'm actually going to ask him to introduce himself, and then he's going to kick us off with our first bit of information.
Awesome. Thank you, Jacqueline. Welcome, everybody. Yes, good morning, good afternoon, wherever you are currently tuning in from. So yeah, my name is James Puckett. I'm an associate lecturer at the University of Wisconsin-La Crosse, where I teach in the psychology department. I'm also in private practice as a clinical therapist with specialties in trauma and addiction. I'm also a national level trainer. I train for the National Center for Youth Opportunity and Justice, where I do a lot of work with kids in the juvenile justice system. I was a therapist at a juvenile detention facility for a number of years, and about 19 years of my experience has been in juvenile justice with the demographic we're going to talk about today. So I'm very happy to be here. It's a pleasure and an honor to be with you today, and look forward to some good learning. So before we kick off with the information, what I want you to do is I want you to think of a youth or perhaps somebody that you worked with that has been particularly frustrating with you. We all have worked with people who we just feel like we can't reach. And then our perspective of what's going on really does shift. And my experience has been, it's good to ground ourselves with a particular client or a case to look at this through that lens to help understand the people that we're trying to help better. Now, sometimes you may be thinking, well, when are they going to learn their lesson? Or you're sick and tired of putting out fires. What in the world were they thinking? They keep making excuses. They clearly don't care. I care more than them. Now, if you've thought that way, and chances are most of us have, think about how it's impacted our work to connect and understand people holistically. Next slide, please. When we work with our clients in our particular cases, they don't come to us with a single issue. They are, consider a kaleidoscope, and the different parts of a kaleidoscope that makes the visual. Well, when we work with people, they're bringing us everything that comes with them. Things from where they're at with brain development, the impact of substance use on brain development, the impact of trauma on their life, the impact of racism in their life. But also think about the other things too. These folks are worried about having their basic needs met. They're worried about school. They're worried about fitting in with the latest styles and the latest fashions. They might be worried about things like COVID in the past year and a half. How many of our kids have increased anxiety due to COVID? So when they come to us with a complexity of issues. And it's very important for us to go below the surface of the behaviors they present to us to arrive at a place where we can work with them in a holistic way.
So like James said, clients that we work with have these various pressures against them, and they're in these varied states of development of their childhood and their young adolescent development. But what we wanted to do today was really hone in on some specific topics, some specific items to explore a little bit more deeply. Like James said, some of these youth deal with not only high score ACEs scores, which James is going to talk about, or the impact of substance use disorders on their developing brain, but they're dealing with peers, or they're dealing with different family dynamics, or school limitations in school. But we wanted to have this structured focus today on a few of these topics because we think that they have kind of a heavy impact on a lot of the behaviors that impact our youth in our juvenile drug treatment courts, or even in our juvenile justice system. So there's these varied internal and external factors, and we just wanted to kind of focus in today on a couple of them. And so one of them that we want to talk about today, of course, is adolescent brain development. And now most of us have had lots of adolescent brain development training. You might be new to the field. Maybe this is something that you touched on briefly in college, or have maybe read an article or two. So I didn't want to spend the sort of the classic lecture today on adolescent brain development, because we've actually heard about this quite a bit, and because there has been quite an emerging research over the past 20 years on adolescent brain development. But James is going to talk to us a little bit about development and trauma and historical and systemic racism on brain development as well.
Yeah, thank you, Jacqueline. So now we're going to start intertwining the tenets of things of like attachment, development, like Jacqueline just said, but also trauma, the impact of trauma, the impact of substance use, addiction, and mental health disorders. So many of you have seen this diagram, Maslow's Hierarchy of Needs. And really what it shows is what people need to thrive and grow. And when we say normal development, what we mean is, the way it needs to be to have that healthy brain development, for that prefrontal cortex to come online when it needs to. That way our youth and the people that we work with are thinking rationally, being able to predict outcomes and making just good, sound decisions. So the physiological needs, which is the base of our developmental needs. So food, clothing, water, shelter. Now just stop and think for a minute, the people that we work with, how many of those are food insecure, have faced eviction, live in domestic violence shelters, homeless shelters, and so on and so forth. It's really, really hard to go to school to learn math when you're not sure when the next meal is coming from, or if mom is safe at home, or if there's anything potentially going on when you get home. It's very, very hard to focus on those things. The next ladder is safety. Now, this isn't just physical safety. This is also emotional safety, where we want people to feel safe and comfortable coming to us with their needs and their thoughts and their emotions. Many of the people we work with do not feel comfortable doing that. They put on a front, so to speak. The next rung is loving and belonging. So who do you connect to? Now, just think about the importance of connection and attachment with the people that we work with, and the lack thereof. Esteem needs. So we all got to feel good about ourselves. And a lot of our esteem needs, most of our esteem needs, our senses of worth, come from our caregivers. And finally, self-actualization. So this is where people realize their potential. I would argue that as a lifelong learner, we actually never meet self-actualization, but you know what? That's okay. We need to remain curious, because as time goes on and our roles in our lives change, we're going to look at the world really differently. Now, these needs, the physiological, safety, loving, belonging, esteem, and self-actualization, as I already said before, is absolutely imperative for healthy development. But it is also what the great addiction specialist Gabor Mate says is how you heal trauma and addiction. Now think about that for a minute. This is how to live, to put it in pop culture terms, your best life. But this is also the path to healing too. I subscribe by the belief that behaviors are the result of an unmet need. And I'm going to give you two examples. One is from a book called In the Realm of Hungry Ghosts by Gabor Mate. They talk to these adolescents that live in British Columbia, Vancouver, British Columbia, Canada. And they essentially ask the question, well, you know, what do you get out of using methamphetamine? And the adolescents said, well, it does two things for us. Number one, we're homeless. Methamphetamine keeps us awake and alert. Being homeless is very dangerous. So if something happens, I will be alert enough to protect myself. And the second part of that is stimulants curb appetite. When you're homeless and you're food insecure, if you're not worried about being hungry, you can go about your day and function and protect yourself. Another example I want to give for you to consider too, especially with the kids we work with, is human trafficking. How many victims and survivors of trafficking have ended up becoming addicted to a substance just to get by? Not only to deal with the trauma that they go through when they're being exploited, but it also, when we have victims that are hooked on opioids, for example, they don't want to become dope sick. So the income, the payout is to continue using that heroin, that Oxycontin, and so on and so forth. Now, when you think about behaviors as a result of an unmet need, I'm going to look at opioids for an example. When people use opioids, they often describe it as a warm hug. Now think about how many youth we work with that just needed some more hugs and some more love in their life. And because they didn't get it, they may turn to using. Another means to an end is think about how many of our youth use in groups. And so that feeling, that loving belonging, that feeling like you're protected. Going back to the safety thing, how many of our people that we work with numb out feelings due to traumatic incidents? Finally, the thing I want to point out about the needs specifically is about 25 to 30% of people addicted to stimulants meet the diagnostic criteria for ADHD. So what does that tell you? They are mood altering to tune in, to dial in. And about 40% of people that are addicted to alcohol or marijuana meet the diagnostic criteria for bipolar disorder. So these folks are self-medicating in a way to make themselves feel safe. If they're using as part of a group, that loving and belonging, and you know, gang membership, for example. Think about how many of our youth are involved in gang membership where they're part of a group and they feel good. They feel respected by other people. Trauma is a very, very specific thing, and we're learning more and more about it every year, it seems like. So trauma results from an event or series of events, which is called complex trauma, or a set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. Now, we have three components of trauma. We have the events, so we can name those. Experiencing a loss, all the forms of abuse, sexual, physical, emotional. Living with a caregiver who they themselves struggle with addiction or a mental health disorder. The other component is how they experience it. Was it life-threatening? What was going on in through their lens, through their perspective of what was going on in their life? And finally, the effects, so the short-term, long-term. So the hypervigilance, the nightmares, the flashbacks, the self-harm, the suicide attempts, the substance use. Do our kids learn to become violent to protect themselves? And from the UCLA PTSD scale, there's about 23 different categories of trauma right now that we use to when we're doing an assessment for PTSD. What I like about the UCLA is it tells us something very important, that trauma can be experienced in 3 ways. Number 1, you're the direct victim of it. Number 2, you witness something. You witness a shooting. You witness a parent being beat up by the other parent. And the third one is you learn about it. And I'm going to give a quick example of learning about it. I worked with a gentleman about 3 years ago who came to therapy due to anxiety. And his anxiety began when his friend was shot and killed in Iraq by a sniper. And his friend's parents gave him kind of a play-by-play of what happened, of how and where he was shot. Now, he was not in Iraq. He didn't see a picture of his friend after he was shot, but the visual envisioning what happened to his friend really derailed him and created an anxious presentation. So when people are sharing their stories with us, it is very, very important for us to, number 1, listen actively, but also not say something like, well, you weren't there. Well, it didn't happen directly to you. We know now that it can be experienced through multiple different ways. Many of you have heard of ACEs, the Adverse Childhood Experience Study. To me, it is one of the, if not the most important, outside of attachment research, one of the most important studies to ever happen. And I'll give just a quick play-by-play. What ended up happening was it came out of some Southern California obesity clinic where people were dropping out. People that did well in the clinic would leave the clinic, and there was a high rate of relapse. And so there's one story I typically cite from a woman who had lost 100 pounds like 4 or 5 times. Now think about that for a minute. You drop 100 pounds and you gain it back. How many of us in this audience right now have been struggling to get that last 5 pounds off, and how just frustrated we get? Well, this woman did 100 pounds multiple times over. So she comes back to the clinic, and the folks at Kaiser Permanente were just like, hey, you do great in treatment. You leave and something happens. Talk to us about it. And what she did was she shared that when she would drop all this weight, people would comment on it. And it wasn't misogynistic from what she reported. People would say, you look really nice. You look great. You look beautiful. Well, what happened is when she heard you look beautiful, there was a cascading effect of stuff, I'll just call it, that happened to her. What it did for her was the word beautiful brought her back to a place in her life where she was called beautiful after being sexually assaulted by a bus driver, uncles, her father, and brothers. So that word beautiful was a triggering word for her. And so they started asking questions of all the participants at this obesity clinic, is this something that you've experienced too? And what they recognized, and this is one of the first time that food was seen as a mood altering substance, was that people were basically mood altering through food. What's more interesting about that is prior to arriving at food, many of these people had maladaptive behavior around using things like alcohol, cocaine, and marijuana. So the alcohol, cocaine, and marijuana preceded the food addiction, if you will. And what they found out was there was a high prevalence of sexual assault survivors among those at the obesity clinic. And so they set out to do this survey, over 17,000 middle class, which is important, predominantly white, which is important, 44% educated. But keep in mind, this was 1998 where industry jobs were still around. You didn't need a master's degree to have good, decent health insurance and a living wage. This was back where, shipping docks were alive and kicking. We weren't outsourcing, companies like Goodyear and so on and so forth. And then they also asked them about their health survey and then the 10 ACEs questionnaires. And you can look at that in your own time. But what they stumbled on was a shocking prevalence of people who experience all sorts of abuse, neglect, experience somebody in their life that had been incarcerated, experienced some sort of abandonment. This became very, very commonplace. And from the ACEs study, we know that if a male has an ACE score of 6 or higher, we know that their risk of being an IV drug user goes up almost 5,000%. We also know that if you have an ACE score of 4 or more, your risk of becoming somebody dependent on alcohol goes through the roof, as with suicide, as with depression. Now, here's where the connections need to be made. Unless we're able to make the connections, this study doesn't do us justice. Well, number one, to be an IV drug user, as you may know, you have to be pretty knee deep in your addiction to use so. Nobody, as I was told by a client earlier in my career, you don't graduate to the needle immediately. It's a progression. And we know that people that use substances and people that are struggling with addiction are more susceptible to other traumatic events. Now let's talk about alcohol, depression, and suicide. Well, we know that depression is a major risk factor for suicide. Matter of fact, some studies say that it increases the risk of suicide 10 times. And the number one drug associated with non-premeditative suicide is alcohol. So when we're talking about people's substance use, we also need to be aware that that is a symptom of something greater that has gone on. Now let's move to the Philadelphia study in 2014. And what these folks did was they took the ACE study and they took it to a more urban environment. And then they added new categories. And off the top of my head, they were bullying, they were experiencing discrimination, unsafe neighborhood, being in foster care. And the other one is slipping my mind right now, I apologize. But when you add those to the layer of the 10 originally, now we're starting to see that kaleidoscope come. Okay, this is what happened to you. This is not what is wrong with you. This is what happened to you. Knowing what was going on with the Philadelphia study, racism in itself is an adverse childhood experience. It is people that experience that type of discrimination. And something else we need to take in consideration too is a term called social determinants of health, and that's a public health term. But let's be honest here: addiction and mental health is a public health issue, not treated as such sometimes, but it certainly is. So social determinants of health includes things like poverty. It includes the household you grow into, your culture, access to education, and access to healthcare. Access to healthcare is a tricky one because people think that because you are close to a medical facility that you're all good, or if you have health insurance, it's all good. Public health tells us that access to healthcare is only 15% of total health. Then we have components like intergenerational trauma, where essentially habits, beliefs, perspectives are passed on and behaviors are passed on. And then we have, our health outcomes. So African Americans, for example, have a 4-year lower life expectancy rate than white Americans. Puerto Rican kids that live in Chicago have a higher rate of asthma. Well, think about some of our poor, impoverished areas. We have establishments that still have lead paint, which has been connected with ADHD. We have poor water supply, as we've seen in Flint, Michigan, and other parts of the country. We have rat-infested environments. So it's not just what's going on the inside of the body or the brain, but it's our surroundings and our bigger global surroundings. One thing I want to talk about too is genetic predisposition. Those of us that are working with clients that are struggling with substance use or addiction, we sometimes fall in the hole of, their mom drank, their dad drank, they're just genetically predisposed with it. Well, the reality is our environment turns on our genetics. It turns on our genes. Just because a child comes from a family where there are two parents struggling with addiction, it doesn't mean that that's their fate too. Something to remember. Two things I would encourage you to check out is if you type in YouTube John Henryism, there's a professor from the University of North Carolina, Chapel Hill, that talks about health outcomes among African Americans in the South and how racism has impacted them. And then the BBC did an interview with an Iraqi war vet who is from the south side of Chicago. And so if you Google BBC, Iraq and Chicago, you can watch their interview. And what's interesting is from the year 2001 up until today, more people were killed in Chicago from violence than Iraq and Afghanistan combined during that time period. That's 4 hours away from me. And that is just, it's quite shocking. So with all this around us, we have people that are highly traumatized and are very, very susceptible. And I think that's it for that. Jacqueline, I'm going to turn it back over to you.
Thanks, James. And I appreciate you sharing this information, this connectedness between racism and health. For those of you that are interested, James just gave some good resources, but there's another resource that I wanted to point out to you, which is the Center on the Developing Child at Harvard University. They have a lot of resources, various studies and that you can download and read about how racism can impact and affect the child development. So they do a good job of summarizing all of the research and show that these years of scientific study show that when a child's stress system remains highly activated in those early years of childhood development, it can have significant wear and tear on the developing brain and other biological systems. And then you take that and you combine that with, there's research that suggests that that constant coping with racism and discrimination is an activator of that stress response system in the brain. So not only can the child experience it themselves for our youth that are from our communities of color, but also their observation of it in their environment, where their parents struggle with discrimination or lack of access to education or housing or healthcare. So it's really multifaceted and really important to think about in terms of an adverse childhood experience and a social determinant of health for our youth of color in our programs. Again, that site is the Center on the Developing Child at Harvard University, a great resource for our programs. Okay, so we've talked now about you're dealing with an adolescent who's in the middle of brain development. Many of them come from these environments where there has been trauma. James talked about adverse childhood experiences. And James, I'm not as familiar with that research as you are, clearly, but it sounds like really it doesn't take a lot of a very high score on the ACEs scale to really have some needs, right? And
can I say one more thing too? So what we
Please.
know about trauma specifically is when you look at the statistics, women and females have a higher prevalence of PTSD, for example, and trauma. 80% of all autoimmune disorders are comprised by women. And we know autoimmune disorders are the cause of a weak immune system. Well, what weakens an immune system? Stress hormones, adrenaline and cortisol. And also take into consideration, if you have a kid who has a trauma history and lives in an impoverished environment and has asthma, well, what do we do to help that kid with asthma? We give them an inhaler, which is more hormones. And anybody that has witnessed an asthma attack, it's not just about getting the lungs in a place where they can breathe again, but that whole nervous system, they can't breathe. So the fight or flight is kicking in. So it's this constant cascade of stress hormones. And can I make one more comment and then I'll let you go? I'm
Absolutely.
sorry.
No, it's good stuff.
In the book, The Body Keeps the Score by Bessel van der Kolk, he cites a study that took place in the 80s where they had unbelievable retention of the participants. And these were all young women, sexual assault survivors. One of the things they found was when the young women were sexually assaulted early on in life, I'm talking 10 or below, some of them begin to secrete sex hormones at a very young age. Well, what does that mean? Well, number one, we have hormones involved. But now we have a child that's been traumatized. And if you think about Maslow's hierarchy of needs those needs to be met for, to feel whole. So if they don't have healthy attachment, what is happening to them is, number one, they're looking for the attachment needs, oftentimes in very wrong places, unhealthy places. But now their body is biologically, the clock is ticking, so to speak. The biological clock for these young girls is ticking. And so you think about just, again, the kaleidoscope, the connectors of everything. So when we were working with young women and young girls specifically that may come into our courtroom or office with a reputation, please take a deep breath and pause and ask yourself, I wonder what happened to her. I wonder what happened to her that makes her, have the reputation, if you will, come forward. So thank you for allowing me to get that in, Jacqueline. I appreciate it.
No, I think that was important, James. Thank you. Okay, so we've talked about where they're at in their brain development, and these classic adolescent behaviors, right, of risk taking and forgetfulness and their sleep patterns, all of that, understanding that in that context. Now, understanding the impact of trauma and historical and systemic racism for our youth of color. Now let's talk about the impact of substance use on the developing brain. And then we're going to switch to talking about some motivational interviewing techniques to use with youth and some ways to frame our language with youth when working with them to think more through that behavior lens, given everything we know. So there is an emerging research on the impact of substance use on the developing adolescent brain specifically. There's been both animal studies and human studies, clinical trials. There's neuropsychological studies that have been done on alcohol use disorder in adolescents and found that, for example, those youth with AUD, adolescent use disorder, can have poorer verbal memory, they have attention problems, they have issues with even executive functioning at times. And similar to those studies on alcohol use disorder, when we're looking at cannabis, for example, I know that is a prevalent drug in our juvenile drug treatment courts, in our juvenile court systems. It is, just very culturally accepted among our youth population. And so there is an emerging and sort of converging line of evidence around the impact of cannabis use, chronic cannabis use on the teenage brain. And there's preclinical studies that have shown these cellular changes in the brain. And what the studies are showing so far is that the earlier the marijuana onset, the earlier the onset of use, so starting before that age of 16, that is associated with more severe consequences around psychiatric symptoms and even around reduced overall or verbal IQ. And so poorer attention, like in the alcohol studies, we have some studies have shown poorer attention and again, impact on that executive functioning. And so what I want to do here now is just kind of share a little bit more in depth about two studies. And then I want to also talk about where a very large study that's happening right now that I think is very relevant to our field and the work that we do, and that I think will prove quite insightful. So this is a study that basically looked at, it's a study from Australia. It looked at 6,900 individuals at different ages. So it was a longitudinal study, and it looked at depression scores by dose of cannabis and years. And cannabis use, as you could see down below here, was ranked from never to less than monthly, more than weekly, or even several times a week or daily. And the reason I'm sharing this slide here and this piece of information, this study, is that adolescents often will tell us that they use marijuana, they use cannabis because they think it helps calm them. They think it helps with their anxiety, and it helps them if they've been feeling depressed. And of course, it's a very social drug as well. But really what this data is showing us here is that if you're looking here at this top line with this top line, those are 15-year-olds compared to the 30-year-old population. And so when the data are looked at by age, the impact is most pronounced in young people in that 15-year-old population when looking at the difference in the mean depression scores. So these youth are scoring higher in depressive symptoms than someone in terms of that weekly use than someone at that age of 30 years old. And then, one of the findings is really around cannabis use and cognitive impairment. This was another study that was done. This study was done out of New Zealand with over 1,000 individuals. And this study looked at IQ over 20 years, starting at an average age of 13. And then they measured, the cannabis use was measured at certain ages, 18, 21, 26, 32, and 38. And remember, IQ is mostly stable and unchanging over the lifespan. But in this particular study, IQ actually rose a point in the control group where there for non-cannabis users. But the cannabis users, as you can see here, were measured in 4 different waves of follow-up, and regular use of cannabis conferred an average IQ point loss if used regularly, which was and used regularly at 3 or more waves. So in other words, what I'm saying here is that adolescent onset of cannabis resulted in an 8-point loss of IQ over time. Now, this is an isolated study. There's been other studies that have not necessarily shown this heavy of an impact on IQ development, or some studies have shown no impact, for example, on maybe attention or more executive functioning. And so because the studies are, there's some studies that have very small sample sizes, or again, they were animal studies. So there's a large study right now that's happening called the ABCD study. And you can look this study up as well, the abcdstudy.org. That is where you find it. And that is the Adolescent Brain and Cognitive Development Study. And it's a longitudinal study looking at childhood experiences that affect the brain, social, emotional, and cognitive development. So they're looking at everything from sleep and the use of cell phones at night, as kids lay in bed with their technology and their phones, the interruption of sleep patterns and on development. They're looking at attention. They're looking at the impact of substance use on the developing brain. This is a neuroimaging along with survey and interview and other data collection methods, but it is a neuroimaging study. So it's going to be very informative. They already have some publications out. So I would encourage you to keep track of that study as well. Okay, so taking all of this together, how do we really anchor ourselves in a developmentally informed approach to working with our youth? Because again, I've walked in your shoes as a juvenile drug treatment court provider. I've been a probation officer. I've been a coordinator, and I know what it feels like to sit around that staffing table and feel that frustration. James shared those questions at the beginning, those reflection questions where you're just at this state of concern where it feels like you're doing more work as a team than maybe the youth is. And so, what do we do here, especially as we really come to understand not just brain development, but all these other factors that we've been talking about today. And again, there's certainly many other factors that we could be talking about too. But we want to make sure that our responses and our program is developmentally informed and that we take a developmentally informed approach. Now, we need to remember that although it's developmentally appropriate for youth to think about themselves as independent and really not needing anything from adults, they do need adult support. Sometimes they're not going to get that adult support within their home. The team, or different people in the community can really start to be some of that support for this youth. So we need to balance that need for development and autonomy. Remember that adolescents are very resistant to passive learning. I'm sure James could talk about this as a treatment provider and therapist. They don't want to they don't want to sit there and just have somebody lecture at them, right? They need to have energetic, fun activities. So for judges from the bench, the more you can do to really engage that youth from the bench, and not just talk at the youth, you're talking with the youth. Don't make the program something that's happening to the youth. Let the program happen with them. Engage them around not only the therapeutic content, but the process that they're going through in our juvenile treatment court. We have to keep remembering that thrill seeking and risk and deviant behaviors they're problematic, clearly, and can lead to trouble, especially when they're using substances. But those are normative as well. And so we have to balance that, our responses. And we know that we get better behavior change out of rewarding positive behavior than we do using the punishers. So every chance we get, we want to make sure that we're acknowledging and rewarding our positive behaviors and allowing the youth to have voice and choice in setting some of the goals that they're going to work on. When we just sort of, give them all the same case plan, all the same treatment plan, and we don't ask them what's motivating for them or what maybe some sort of small goals are that they want to work towards in those high risk domains in their lives, we're just not going to get the responses and the progress and the growth that we really are looking for. So we want to be, really weaving this safety net of supports and thinking more about youth in terms of helping them build up what we call recovery capital. So helping them build up their personal and their social and their community and cultural capital. And so sometimes that means outside of the family, finding those natural supports in the community where this youth can make a connection. Sometimes that is family members. Sometimes it's an aunt or an uncle, or it's a coach, or it's somebody down at the art center or down at the skate shop. It can be pretty varied. And so we want to think about that too. Really, it's about relationships. And so James is now going to share, we have a couple slides here, really thinking about some ways to use some motivational interviewing skills to connect with these youth.
Yeah, relationship. And we keep a relationship going by making sure we're checking our stuff too. You're going to hear some horrible stories. You're going to see some horrible things. Please take care of yourself so you can remain very, very objective when you're looking at things. Lead through empathy. And simply what that is, picking up the file, reading the social history, and just asking yourself, I wonder what it must be like to go through this world with this experience. So a couple just examples that are more inviting, more motivational, and you can kind of figure out where these would come into play. But, you're working with somebody. Can you talk to me about other people in your life that have been in this situation? These are all supposed to kind of evoke more conversation, because if you ask them kind of a straightforward, if you word a question a certain way, more times than not, you're going to get the answer, I don't know, or just a shoulder shrug. How has this helped you and how has this hurt you? So I like that question when I talk about some of these substance use. Well, what do you like about alcohol? Has alcohol caused any problems for you? Get to know what they are subsidizing. Then you get to learn the need. If they tell you why they like it, you have a fast track to the need they're trying to fulfill. Think of Maslow. What is your understanding about the concerns we have for you? So like we could sit here till we're blue in the face saying it's illegal, health issues, asking them directly, do they know that we're on their side and we want to help them? How might you know it's time to make a change? I'm not ready to quit yet. Well, when do you think it'll be time to make a change? What's your best guess? What's your best guess about what it would be like to trust yourself again? Because when you peel back the onion, especially when it comes to mental health, a lot of this is about trust, not knowing yourself. Learning over the course of time that I can't do anything right. One of the things that we do in our work is we try to build confidence and self-efficacy. Change is a hard process, and I look forward to walking with you on this journey. So, boy, just the power of walking with you on this journey, what it can do to some kids and for their families is really quite powerful. The other thing too to remember is that when we're making referrals for mental health therapy or parent coaching or parent supports, please ensure that the professionals that you're bringing on the team are trauma informed. They're not chasing behaviors or chasing symptoms. That's going to lead to further maladaptive behavior and avoidance techniques, and they're not going to show up. All right, next.
James,
slide.
James, real quick here though,
Yes.
before we switch this slide,
Yeah.
how could you see some of these motivational approaches being used by, like, say, the judge or the prosecutor even, or the public defender in some of these teams, in the courtroom or even outside of the courtroom? I wasn't sure. What are your thoughts about that?
Yeah, so I think when people are given a platform to give a voice to their experience, we can join with them easier. I think a lot of people in our system, every single person I think in this session here, we all come for professions that really have kind of an ugly past, to be honest with you. When you think about the war on drugs and what it has done to families and how we criminalized, poverty and mental health and substance use, we never asked questions. We never went for the needs. We went to the behavior and said, you're bad, this is bad, that means you need to go away. These types of questions are inviting, and we get to learn more about them. I have a big belief, and I when I'm working with my students, future therapists, I tell them this: our clients will talk to us about what we're willing to talk to them about.
Mm-hmm.
If we don't talk to them or ask them these, tough questions or what seems to be enabling questions, they're not going to bring it up with us. No one's going to volunteer why they like pot. They'll cite some study about how it's effective, but it never goes to the core of why they like it. Our people will talk with us about what we're willing to talk to them about. That's very important, whether you are assessing a suicide, a safety risk, or you're talking about their drinking patterns or their violent streaks where they feel like they have to defend themselves and keep themselves safe. Does that kind of answer the question?
Absolutely. And I think it's actually a great segue into this final slide, which is that how we talk to them, why delivery and language matters. So,
Yeah, so I'm not going to go through all these, but I think it's a very trauma informed. It's kind of like bedside manner. I mean, think about if you were to walk into a doctor's office and it's a tough situation, how you would want to be treated. We want to be more inclusive and less stigmatizing. So, and I used this word before, and trust me, this is going to be like a learning curve for all of us because we're just recognizing the power of language. Instead of calling them addicts or junkies, talk to them and call these, the folks we're working with, people that are struggling with addiction. Don't call them a schizophrenic. Don't say that they're depressed. They're struggling with depression. They're struggling with schizophrenia, symptoms of schizophrenia. A traumatized person, they've experienced trauma in their life. Kyle is non-compliant or resistant. Part of the makeup for adolescents is to be a little non-compliant and resistant. So we're just calling, we're just saying water is wet at that point. But right now, Kyle's not choosing to participate. Kyle's not really ready to participate yet. Giving up alcohol is too scary for him right now. Jennifer is in denial. She's a bit ambivalent. This is where she's at in her stage of change. She hasn't experienced enough consequences to want to make a change. So being able to talk in a more inviting, trauma-informed, person-centered manner, I think can invite people in and keep them with us, not go astray.
Yeah.
And truthfully, it's about trust building too. They can trust themselves. They begin to trust us. And when they remember with trauma too, people are the most traumatized when they're abandoned in their biggest time of need. And we're in positions right now where our folks we're working with are going through quite a bit. So we have an opportunity to be that person in their time of need.
Yeah, excellent, James. Thank you. And we promised you we had a lot of material for 1 hour, and we're pretty much at the 1 hour. I know Jessica comes back on the screen. It tells me it's time to wrap things up. But here's our contact information for me at NADCP and for James at the University of Wisconsin. I also wanted to remind all the participants that if you are interested in some training and technical assistance for your juvenile drug treatment court, we have the ability, NADCP and the National Council of Juvenile and Family Court Judges, to offer training and technical assistance to your organization. You can apply through OJJDP through a process called TTA 360. I'm not sure, Jess, if anybody could pop that into chat real quick. But we are able to provide virtual training right now at no cost, and then we hope to be able to travel at some point in the near future. We could even come to your jurisdiction. If there's maybe something here that you thought, I really want to dig into some of this and think about how we make our staffing more reflective of adolescent development, how we make our case management and case planning more reflective of development, how we restructure our phases to really be more adolescent development and behavior focused. So we're here as a resource for you, and we look forward to hopefully working with some of you in the future. And Jess, I'll turn it back to you.
Okay, well, that was a big part of my spiel, that we do have training and technical assistance available. I did put TTA 360 into chat. I also tried to throw in all of the different resources you guys were talking about. We will also post links to all of these resources when we post the video of this webinar. So if you didn't get a chance to click them all open, it's okay. We are putting right now into chat, Malika is going to put in the link to the evaluation for this. We do want to make sure that we get your feedback about how the webinar worked for you. And so hopefully you'll take a minute to complete that for us. Otherwise, I just wanted to let you know our next Tune In Tuesday is going to be live at the big drug court conference. Hopefully we're all there in person. We get to see each other. Maybe we're not hugging yet, but we're waving across the room. So I hope you're all planning to attend. That's going to be in August 13th through 15th. Am I right, Jackie, on those
Yes.
dates? Yay. Okay, in National Harbor. So if you haven't registered yet, talk to your folks who give out the money for those things and get yourself registered and attend. It's going to be a good time. All right, thanks everybody. We'll see you hopefully in person in August. Otherwise, our next one's in October. Thanks everybody.
Thank you.
Thank you.